Hey everyone. So for those of you who are joining on Zoom, my name is Matt Ehrenberg. Just a little bit about myself. I graduated from a small liberal arts college in the College of Worcester, in Worcester, Ohio. There I studied Spanish and another thing called Communication Sciences and Disorders, which is kind of a pre-professional degree to become a speech-language pathologist and or an audiologist. The reason why I want to become a physician scientist really comes from a variety of undergraduate and postgraduate experiences. I'd say pretty early on in my life, my parents raised me in a way that I felt that having a career or an occupation that centered around helping other people would lead to a life that was really fulfilling. Inherently, I was always interested in some sort of career in which I was involved as a public servant. And for me, the reason for becoming a physician scientist is because I want to be the most impactful as I possibly can be. And from my perspective, the way that I can affect the most change is hopefully by taking my clinical practice and translating the things that I get from my patients in clinic, doing some research in the lab that's relevant and pertinent, and then hopefully translating it back to try to affect clinical change. Thanks.
All roommates.
No, don't do that. You're all roommates. We'll just make that known. And if you guys want to have your masks on while you're up there, that's fine.
All right. My name is Morgan Eliasson. I graduated with a degree in accounting and a master's degree in accounting before going into public accounting and working in public accounting for about 2 years. And then I worked in accounting again for backcountry.com, which is an online e-commerce website that sells a bunch of like ski gear, climbing gear, and clothing. So my path to becoming a physician. So the reason I want to become a physician, I think much like many of the people in this room, is because it's rooted in an interest in helping people. And choosing medicine specifically to do so really sprouted in an experience I had as a completely untrained first responder to a really bad head-on car collision in rural Bulgaria. And through that experience and kind of helping to save somebody's life, was really kind of introduced to a new tier of fulfillment that I had never experienced, never really even come close to recognizing at that point in my life. But also coming away from that experience in the accident, I made a commitment to get more training, at least some kind of basic first aid training. So if I was ever in a situation like that, God forbid, or if it's involves a family member or a loved one, I could be more useful and actually do something in that situation. So that led me to an EMT program, which then led me to join Ski Patrol in Utah, and then started volunteering and started joined a research team in the emergency department. And so you can kind of tell all of these different experiences really cascaded and started tipping the scale to the point where it was quite obvious to me that medicine is really what I was passionate about, and I was ready to switch careers away from my accounting career.
Hey everyone, I'm Connor. Before coming here, I graduated from Vanderbilt with a degree in human and organizational development with a minor in corporate strategy, really just focused on blending psychology with business, and throughout college did a lot of healthcare related internships, from working at a large hospital management company all the way to a healthcare startup with only 6 people. And from those experiences, I really wanted to get involved more in the healthcare industry and did healthcare consulting for a couple of years, specifically working on improving patient experience and care access for patients in cancer centers and surgery centers. Through that, worked really closely with doctors and realized that they were able to do a lot of aspects of my job that I enjoyed, but also got that, clinical and patient interaction. And I always felt like that was something that was missing from my experience. Even talking to patients, I didn't understand a significant portion of, the conversation. I couldn't, fully understand what they were going through. So, in order to be the best possible healthcare leader, I thought it would be, a great move to move into medicine and, talked with a lot of family friends and family members that are in medicine made this decision. Awesome. So moving right into our presentation, we're going to be doing a discussion on My Own Country, the book that everyone read over the summer. And then specifically, we're going to talk about the AIDS epidemic and LGBTQ plus issues related to healthcare. A quick disclaimer, we only have 10 minutes to do a short presentation. So as I said, the focus is going to be somewhat narrow, even though there are many other things that we could talk about. It's going to just focus on the things that was mainly discussed. So specifically, the AIDS epidemic started up in 1981 with cases sprouting up in California and New York City. And largely, the AIDS epidemic was framed as a homosexual male disease, not only in the media, but also in literature. And we'll get to some stuff later in the presentation, but this really led to discrimination towards this group and an overall stigma related to the disease. Additionally, it was framed as a disease only impacting large cities. We saw that in the book a lot as, when Dr. Verghese was treating patients, people always thought that he was bringing, AIDS to the community, not believing that they could have AIDS in their own community. And I think part of this sprouted up from a lack of concern from government figures, especially early on in the epidemic. The Reagan administration didn't put a big emphasis on it, and specifically, Reagan himself didn't address AIDS publicly until 1985. And I think this helped build a culture of fear around AIDS, as people didn't really know what specifically it did, how it was transmitted, and how it really impacted people. I think that builds into next slide, specifically talking about discrimination against people with AIDS. So there were Gallup surveys throughout the 1980s, and I collected a few pieces of information from those surveys. And the first one is 44% of individuals reported that they or someone they knew would avoid places where homosexuals would be present, just because it's popularized as this gay disease. Even though many people in that community weren't affected by the disease, it had spread in terms of discrimination to that entire group. Additionally, roughly half of those surveyed believed that it was people's own fault that they contracted AIDS, and 60% of people believed that people with AIDS should have to carry a card noting that they have the virus. I think you can all see that that's pretty problematic and increases the stigma around the disease, and also increases the likelihood that people don't want to talk about the disease or don't feel comfortable, which we saw a lot during the book. Specifically relating it to My Own Country, I think it was an interesting time when Dr. Verghese came to Johnson City as HIV cases were increasing. And I think it was interesting to see his own growth compared to a lot of the other clinical providers in the area, especially with the nursing staff. A lot of them wanted to avoid treating these patients and didn't even want to talk to any of the patients, and again, blamed him for bringing the patients there and just wanted him to do something different. And also the perception of the cases of people like Will and Bess Johnson, who Mr. Johnson got AIDS, HIV from a blood transfusion after a heart attack, and those people viewed him as more of an innocent victim of the epidemic rather than other people who they would deem having promiscuous sexual behavior, and those people are being the deserving ones who get AIDS. And I think for all of this, it's interesting that when the progress started happening in terms of the federal government, in terms of the Ryan White Care Act, which was support in terms of funding for AIDS-specific research, its poster child was Ryan White, this individual who had hemophilia and got AIDS from a blood transfusion. And so I thought it was ironic that they framed it as a disease affecting mostly gay people for the longest time, and then their person that they're reflecting as the savior of this crisis is just a teenage kid from Indiana. Again, they would probably identify as a the victim of this epidemic. And overall, I think early on there was a lack of treatment options, which is not the case anymore, but Morgan's going to talk about some of the ways why we have different problems. So.
All right, so jumping ahead to modern day HIV in the US today, 38 million people are living with HIV globally today, about 1.2 million of which are in the US. Annual infection rates have dropped about 60%, 66% since the heat of the epidemic in the mid-80s. But unfortunately, since 2014, those rates of decrease in new infections have plateaued significantly. Geographically speaking, highest rates of HIV infection in the US tend to be in the southern states. And it should come as no surprise that unfortunately there's a disproportionate impact on certain population and ethnic groups, particularly ethnic minorities and gay and bisexual men, with about 69% of annual new HIV infections occurring amongst gay men. So this graph, is kind of just combining those two factors together, showing that African American gay and bisexual men are by far and away the most impacted, followed by Latinx gay and bisexual men, white gay and bisexual men, and then the first heterosexual group is African American heterosexual women. So to kind of categorize the present day challenges that our healthcare system is facing in regards to HIV, categorized it into three different categories, starting off with diagnosis. So about 45% of individuals aged 13 to 24 who have contracted HIV are unaware of the fact that they have HIV. So 45% of people ages 13 to 24 don't even know they have HIV, which is an issue for their own health, but obviously for transmission, that's extremely problematic. Only 14% or so of middle to elderly folks who have HIV are undiagnosed. So then moving to treatment challenges, as far as solutions, there is an antiretroviral therapy drug, which lowers viral load in HIV patients almost to a non-existent level. It's so low that, in fact, that HIV tests in most cases won't even detect that the person has HIV when they're on this ART drug. So ART keeps patients healthy, it helps prevent transmission, but the big challenge here is that, for one, it needs to be administered every day. So if people are required to take some medication every single day, and when we talked about the groups who are most affected by this, it poses a challenge for people, especially if we're talking about people who are economically, financially disadvantaged. The idea of taking a pill every single day and remembering to do that and going to the pharmacist often enough and going to your PCP often enough to receive the prescription, it adds a lot of logistical speed bumps that make it more difficult. Also, ART is about, if you have good insurance or if you're on Medicare, it's about $4,000 out of pocket to be covered annually. If you're not covered by insurance or not on Medicare, then it can run you up to $50,000 or $60,000 annually for full treatment for the year. So moving across to prevention, some of the classical examples, prevention are things like sex education, contraceptive disbursements, needle exchanges, and intravenous drug users. But a new measure came up in the subject of prevention in PrEP. So this stands for pre-exposure prophylaxis, and this sounds a lot like ART, the antiretroviral therapy, but it's actually taken by people who have not yet contracted HIV but are in a high risk group. So people who are taking PrEP are in this high risk groups, and they're just taking it, again, just like ART, they're taking it daily, and it's shown to be effective to prevent HIV 99% of the time. Very similar to ART, it also has to be taken daily, and costs are about the same. So if you have good insurance, or if you're on Medicare, expect to pay about $5,000 to $6,000 for annual coverage. If you have no insurance, it can be up to $70,000 for coverage.
So the two sections that I'm going to be talking about are just kind of a particular study that I found as it relates to access to care. And then I also wanted to highlight just the mental health issues that LGBTQ plus members of the community often face. So this particular study that I found was conducted by a research group at NYU. And the main premise of this study is basically just to highlight that the vast majority of public health surveys that are LGBTQ oriented often focus on sexual health, but very little focus on primary care access. So the premise of the study is more or less just to highlight the issues that members of the LGBTQ community face in terms of their access to primary care. The results of the study by no means are groundbreaking, which is to say, if you have health insurance, it's more likely that you go see a physician. If you don't have health insurance, the likelihood of you not seeing a doctor throughout the entire year, which is what they term as foregone care, is much higher. And if you're enrolled in school, typically you have health insurance through your school, so you're likely to have a primary care physician. So just transitioning to this next slide here. Part of the reason why I wanted to include this particular survey from the Trevor Project, which is an organization founded in 1998. It functions as an LGBTQ plus crisis line or health line. The main reason why, like I said, I wanted to include this is just because we've spoken a lot about stigma against the community as it relates to HIV/AIDS, particularly among gay men, as evidenced in the book. And this particular organization puts out an annual survey where they ask LGBTQ youth to just discuss some of the aspects of their mental health. The results are over 40,000 surveys were returned, and the population that they focused on, or the age group rather, is ages 13 to 24. And before I transition to the next slide, I just want to note, at least for me, how shocking the statistics are. So I think it's just a fair warning more than anything else. So 40% of those who took this survey responded that they seriously considered attempting suicide in the past year. And 21% of those who are transgender and non-binary made an active attempt on their life last year. Of those who considered attempting suicide, 50% of those noted that the reason why they weren't able to seek care or mental health services ahead of time were issues due and related to cost. 40% of those also noted that parental involvement was part of their reason for deciding not to seek care. 10% of those noted that they had been sort of forced by their parents to go to conversion therapy, which essentially the idea is that their gender identity or their sexual orientation is wrong and needs to be changed. So that's the premise. 1 in 3 have been reported being threatened or physically harmed in their life. And almost 30% have experienced some sort of homelessness, being kicked out of their house. So for me, I think the main purpose of all of these slides is just to show that things that affect us in our adolescence carry forward. And no doubt, part of the reason why a lot of LGBTQ members don't seek care is because of the fear and the stigma associated with all of the surveys and experiences they had growing up. My eldest brother happens to be a gay man, and in many ways has had a lot of the experiences that we spoke about earlier. He was on PrEP through his university, covered by medical insurance, paid about $50 a month. He took a public school job as a teacher afterwards, and PrEP was no longer covered. And the payment for it monthly was about $400. he couldn't afford it, so he no longer was on PrEP, which is inherently problematic. Just another small anecdote. He recently went and visited his PCP for some sleep apnea issues, and the PCP noted, oh, were you snoring in the middle of the night? Was your wife throwing a pillow at you? And his response was actually husband. And I think for me, if we're going to take the time to have patients fill out surveys and put their sexual orientation and their gender identity, and we have all these categories and all that sort of stuff. If we're going to make people do that, we should actually care, rather than this sort of performative wokeness about signaling that we care when we actually don't. Or it's considered more true. Anyway, so with that, anyone have any questions, thoughts about the book? Yeah. It might be the case that you have a question for any of us, so feel free. Nancy?
Oh, sorry.
Yeah.
I was wondering, among your research, you found that there was a certain preventative measure that either worked the best or became the most popular. I think from throughout my own country, you hear about multiple solutions, and then each works or they don't work for various reasons.
Right. Yeah. I mean, my focus was mostly on PrEP as being, it being 99% effective. So I think percentage-wise, in terms of the efficacy of the individual measure, it's hard to argue with that. But of course, given the cost barrier and the logistics, there's a lot that plays into which is the most effective overall. But I didn't find that. That's a very, very good question. I didn't find overall what's been considered the most effective. And it's worth noting that it's only been out since 2012, so some time, but hopefully it becomes more and more available and can be used by a larger portion of the population.
Okay, awesome, thank you.
Yeah.
Any of three of you probably get into this. Sexual education is brought up by you. Do you have any metrics on areas that perform only, abstinence only versus, we're going to throw the entire book at you and teach you everything about all these STDs? Any research you found on that?
Yeah, I haven't, but that's another great question. It would be interesting, especially because the research that I did find is how HIV prevalence is spread geographically, and particularly in southern states where there's less emphasis placed on sex education other than abstinence and more emphasis placed on abstinence. That could be a correlation there. But in my mind, I also was recognizing the economical or financial separation that could be a cause of that correlation. So whether that's related to sex education factors, I'm sure it is to an extent, or at least I would guess it is.
If you are in a high-risk group or considered to be a high-risk group, is insurance pretty good about covering PrEP, or is that something where you have to be considered very high risk?
Yeah, that's a good question. I don't know. I would imagine that it's not. They wouldn't cover or not cover based on sexual orientation or something like that, because that's intravenous drug use, sexual orientation, those sorts of things are what are going to determine whether you're in a high risk group for HIV contraction. And I don't know for a fact, believe that insurance companies would use that kind of information to determine eligibility for coverage.
Life insurance companies will.
Yeah.
And if you buy life insurance, they'll come in and draw blood. And one of the things they do is an HIV test. And you'll get an adverse rating. There's nicotine in there, and if there's retrovirus, you get an adverse rating.
Yeah, I was going to ask if you guys came across any cost-benefit analysis of PrEP, which I assume if you had, it would be in favor as a preventive measure for saving money in the healthcare system. But if there had been any historic attempts to use that to negotiate with insurers to cover it more for product with people.
Yeah. I mean, it's a good question. I feel like this is very much along the lines of preventative medicine as a whole, right? It's like the return you get on making sure everybody has access to a PCP, and the long-term effects of that versus paying the state or the federal government paying for people to go to the emergency department when things get out of control, or when they need expensive HIV treatments with hospitalization. So
Maybe if costs have gone down with the other drug art, as weapons become more prevalent in what they use.
yeah, it's an interesting thought for sure. I'm not sure. I don't know the pharmaceutical industry well enough, but I think generally it does, price goes down when patent expires, generic drugs come out. So I'm not sure where it is on its trajectory to know how the prices fluctuate over time.
All right, thank you.
Can you grab kind
So the net effect of the discovery of these agents has actually been what you see with other diseases over time, that it's been converted to a short-term fatal illness into a long-term chronic illness. And sometimes actually the economics don't work out that well. It's actually cheaper for people to die quickly than to keep them alive for 40 years with treatment. So the cost-benefit analysis, you have to be careful about the way that it's structured. Certainly the acute cost of caring for these folks is way down. You hardly ever see them in the hospital anymore. And they're not in the ICU, they're not anywhere. Chronic costs of caring for people that don't die but still require treatment becomes expensive. Another perfect example is insulin for diabetes. Insulin-dependent diabetes was fatal until it was discovered. Now it's really, really expensive to keep diabetics alive. We can do it, but instead of dying at age 5 or 6, they now die at 50 or 60. It's a very expensive life. So the economics don't always work out. A rapidly fatal illness is much cheaper than a chronic illness. That's just go. All right, well, welcome everybody. Welcome back, and welcome to the Zoomers. Who's up for questions? There are 2 of you up who wants to go first. So take your mask off, please. Okay. Just gonna cost. How the death of Justice Ginsburg will have, what effect will it have on politics, and what effect will it have on healthcare? If you didn't think the politics at the presidential level could get nastier, they are going to, because this will be orders of magnitude. Unless some miracle, depending on your point of view, happens, the Republicans will be able to confirm Supreme Court justice in a couple of weeks. It bothers me to see that they're already saying they're going to vote yes when they don't even know who the person is, which leads you to believe that it's really not a selection process at all. The court has never, the court was barely favorable toward the Affordable Care Act when that was in June of 2012. When the Affordable Care Act, the constitutionality had reached the court in June of 2012. They ruled it constitutional barely on a 5-4 basis, with an exception to the penalty or the universal mandate phase, and a bunch of other things have been done since then. It is widely believed that if it gets to them again, that they will rule it unconstitutional, or at least pick it apart again. That doesn't worry me. The backlash against that will be significant because lack of access to healthcare hits everybody, and there are very few people out there who want a large fraction of the population to not get any healthcare. I think, I worry more actually about women's reproductive rights. I think that it's quite possible that the court will overturn Roe v. Wade, and that will throw the women's reproductive rights question back to the states. And so we're going to have some states that liberal and some states that are conservative as far as that goes. I think there is an unfortunately large group of people in the country that would like to impose their view of what reproductive rights on men. That's not, I hope they don't feel that way about healthcare in general, but women's reproductive rights is a nasty subject to get into. And there's religious overtones and other things which you have to respect, but the concept that the will of a minority can be enforced on a majority, I think is quite worrisome when it comes to that. We'll see. In truth, if you try to think about really how cataclysmic is this, we almost already have abortion rights portioned out by state. That many states have made it nearly impossible for a woman to get an abortion without making it illegal. They've just made it so difficult that it is effectively not possible. And they do it by enacting things like requiring that abortion clinics have 8-foot hallways and have a doctor on staff all the time. A whole bunch of nonsense, medically unjustified things, which make it almost impossible to perform abortion safely. So we already have a number of states where it's either impossible or extremely difficult to do. This will, if Roe v. Wade is overturned, all it means is that the states won't have to go through the subterfuge of eliminating abortion without making it illegal. They're just going to make it illegal. And so we'll have a more balkanized country when it comes to access to health care. And I see it only accelerating the divide that already exists. But I'm not happy about it because from a purely healthcare fairness standpoint, it could be quite disastrous. For a long time, those of us that care about healthcare access and government subsidizing healthcare had all our hopes pinned on John Roberts. He was the swing vote, and now he's not the swing vote. If a very conservative person gets put in there, then Roberts is not the swing vote. He becomes a clear platform majority with a conservative majority prevailing. That doesn't bode well for healthcare and in particular women's reproductive rights. Other questions? Who else is up?
Yes, Dr. Powers, I've got a question.
Yeah.
Okay, just out of curiosity, have you looked at, I know people are saying that Roe v. Wade is going to be overturned, but even Kavanaugh and Gorsuch recently have been pretty much abiding by stare decisis and leaving things as they are. I've heard this is just one source also, that the only pretty clear vote in favor of overturning Roe v. Wade would be Clarence Thomas. Do you have other sources that have indicated more would be willing to challenge it, or are you more worried about subsequent decisions that come to the Supreme Court?
I'm more worried about subsequent decisions, and I'm also more worried about people doing what they said they would do. It's all fine and dandy to say that you'll uphold it as if you never have to vote. Recall now that a huge number of Republican senators, including the leadership, are on record as saying we should never have a confirmation vote for a Supreme Court justice in an election year. Oops. And now they're saying never mind. So I guess I would hate to not trust a Supreme Court justice, but if they have at one point said they would not they've never said they wouldn't overturn Roe v. Wade. What they've said is, I like to think that I'll keep precedent in place, but that's real different than the case that comes before them. I would love to be optimistic, I really would, but we'll see. This is a body blow to people that are concerned with universal access to healthcare and in particular women's rights. And obviously depends on who gets put in and depends on how they behave. Over time, if you read the history of Supreme Court, people tend to get move a little to the left or a little to the middle, I should say, once they get on the court. That's been the truth historically. It hasn't been true lately. Clarence Thomas hasn't budged. He doesn't even move, much less budge.
Gorsuch and Kavanaugh have been somewhat less consistently right-leaning in their voting, especially with the recent Planned Parenthood vote.
It's true. I hope you're right. I hope you're right. I don't think this is necessarily bad, but it's worse than it was a week ago.
Okay.
I think that's fair to say.
Thank you.
Questions, anybody else? All right, I do, it is sometimes hard for me to see you raise your hands in here, and it's almost impossible for me to see the Zoom people. So if somebody's monitoring the Zoom people, please let me know. Or just shout. I don't mind if you shout at me. Miriam, got a question?
Yes, I do. So my question is, how do we improve public trust in science?
How about a few softballs here? I don't know. It's hard for me to understand this. I actually come from a family of scientists. My mom was a biology and chemistry teacher, and my dad was a chemical engineer. So in my house, there was fact and fiction. It's very hard to convince somebody that something is either true or untrue when they have a non-evidence-based way of looking at the question or at the subject. And it's very hard. If someone simply says, I just don't believe that, then you're almost into an argument of religion or belief systems, which is really pretty hard to defend. I've actually read that you can read about this. You can read about how do you change people's minds. And as it turns out, presenting them with more facts is counterproductive. You can't, if they don't believe you at square one, they're never going to believe you if you just continue to pile on evidence, because they don't believe the evidence. And so you have to get at why they don't believe the evidence. What is driving their feeling? Because this is a feeling. This isn't a cognitive judgment. This is a feeling that people have. So you've got to get at driving their feeling. And I don't know how to do this. But there's a body of knowledge about it, which I encourage you to read, that has to do with how do you make someone believe something that they don't believe or choose not to believe. But if you can't agree on the sources, it's a dead-end conversation. I witnessed once my youngest daughter taking on her grandfather over a point that had to do with welfare, and his assertion that all the people that were causing trouble, the whole trouble with welfare, it was all black people, and that they were all lazy and they all had 2 cars and cell phones, and that really it had to do with sort of black culture. And she said, actually, Grandpa, there are more white people on welfare than black people. And he said, no, there aren't. And she said, actually, there are. Trust me, I just took a course in this in college, and there are more white people than there are black people. And he stopped for a minute and he said, I just don't know where you're getting your information. And when you get there, that's the end of the argument. Because you can't pull out the book, because then they doubt the book. You can't go to the web page, then they doubt the web page. You can't bring in the expert, they'll think the expert's a phony. So you have to get to the basis of their concern, and it's hard to do. It's really hard to do. It's actually one of the questions I'm going to ask you today. Does that help you, Miriam? I'm sorry I don't have a better answer.
Yeah, I guess I was really thinking about it in the context of like a doctor's relationship with a patient, if you can't get the patient to buy into the treatment plan.
Well, it's one of the questions that arises out of this book that we will get to today, I hope. All right, anything more? All right, a couple of comments to start. One, to just point out that you're all in a different CULT program in a particularly difficult time. And everybody knows this, everybody understands this. It's been made more difficult by the uncertainty and changing environment in living and studying. Even but 2 days ago now, there's new university rules. And I think we can see that this is just going to continue to fold and unfold over time. And the uncertainty is making this, I think, a lot more difficult. What this means even more, I think, is that you and all of us need to take care of each other and take care of ourselves as we move forward. what does that mean? You know, the simple eat well, sleep well, don't drink too much, but also do stupid stuff that makes you happy. Really, you've got to find an escape out there. That might be something really dumb. By all means, get outside. This weather is a gift. We had a miserable summer, and eventually it's going to get colder and darker. But for a while, if it looks like this, figure out how to get outside. Study outside, sleep outside, do whatever you can. But really get out there and figure out safely how you can get outside and enjoy this. Dr. Verghese played tennis. Did you notice how often tennis came up? That was his escape. He actually wrote a second book called The Tennis Partner, which is about his tennis partner when he eventually ends up in El Paso. He goes to Iowa at the end of this book. He ends up in El Paso. Now he's at Stanford. In El Paso, he had a tennis partner who was an EMT resident who became addicted to cocaine. And it's a very interesting book, little short book, maybe 100 pages long, about how the medical profession treats addiction among physicians. And as well written as this book, but an interesting read if you want to get into that. So Dr. Verghese played tennis. I play softball. I'm on an old man softball team. We, you know, how much does this mean to me? We swept the doubleheader yesterday. I got the walk-off in the first game. The other thing happened to me yesterday. I got to the end at work of a very long protracted contract negotiation involving hospices and hospice care and fellowship support. It was extremely important. But I can tell you this morning, the walk-off single means more to me than the contract. So that's, and I would encourage you to find something like that to do. So it's a close call between the ball game and the contract at this point. Maybe later on the contract will mean more, but right now, the wasn't even a clean single, but nonetheless it got to running. So going from there, I want to talk about the book. But I also want to give you an opportunity to answer some questions. What I really want to do is about 3 o'clock. I want to give you about maybe a half an hour, and I want to split you up in groups. And seriously, I want you to go outside. There's a picnic table out here. There's other places you can go. Down behind, there are no more chairs. Is that right? Did we decide?
No.
If you don't mind sitting on the ground, but anyway, split up if you can, and leave this room. You don't have to, but I encourage you to leave this room for about 30 minutes. And come back. I'm going to give each of your groups a question to answer, to talk about and discuss among yourselves. The Zoom people, I want you to split in half, and Jillian's going to do that, pardon me?
Yeah, I'll take care of it.
Jillian's going to take care of that. So the Zoom group, I want you to do questions 4 and 5, which Jillian has, and that means in here we have 20 of you, which means we have 6, 7, is that 20? 776. So 2, 3, 5, 6, 7. All right. Stop here. It's 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6,
Okay.
7. Here.
I'm going to stop recording